Good evening for all APBD patients and for APBD community. For me, it's a great pleasure to take part in this APBD patient chat and talk about the diagnosis and management of bladder dysfunction in adult polyglucosan body disease. First of all, I would like to thank you very much for APBD Research Foundation for this invitation, especially for Natasha, Jeff, and Harriet. My name is Paulo Sgobbi. I'm a clinical neurologist and I work with neuromuscular disease at Federal University of São Paulo in São Paulo, Brazil. I also would like to introduce my friend Dr. Wladimir Bocca. He is a clinical neurologist. He also works with neuromuscular disease at the same center with me. What is APBD? Adult polyglucosan body disease is a rare inherited genetic neurometabolic neurodegenerative disorder characterized by multisystem compromise due to GB1 mutations, and GB1 related disorders represents a clinical and genetic spectrum of glycogen branching enzyme deficiency with abnormal building and accumulation of polyglucosan bodies in many tissues and organs. It's a rare or ultra rare disease, more common in patients with Ashkenazi Jewish ancestry and probably underdiagnosed or misdiagnosed in other populations like Brazilian patients. The typical age at onset of disease is after the 30 years of age, mean between 45 and 55 years, and adult polyglucosan body disease had a classical clinical presentation characterized by a group of unexplained neurological signs. Adult polyglucosan body disease has a typical phenotype characterized by a slowly progressive disease with unexplained neurological symptoms like neurogenic bladder with urinary problems, upper and lower motor neuron involvement with weakness, stiffness, fatigue, and gait abnormalities, painful small fiber neuropathy characterized by abnormal sensation and burning of feet and hands, autonomic disturbance like cardiac problems and gastrointestinal dysfunction, a mild cognitive decline with a slowly progressive course, and a suggestive combination of neuroimaging findings when patients performed a brain MRI. Why is it important to report urinary symptoms? The urinary symptoms are uncomfortable and embarrassing and are related to a low quality of life and are restricted, limited to social activities, and usually is the first symptom reported by APBD patients or by other neuromuscular patients. So it's very important to talking about urinary symptoms with your doctor and with a neurologist because urinary problems can be a first sign of neurological disorders. Urinary and neuropathic symptoms are the top two groups of symptoms that bring undiagnosed patients to the doctor's office. The first evaluation of urinary symptoms is usually performed by non-neurologists like general clinicians, urologists, and surgeons, But it's important that all patients take in mind that urinary symptoms are a neurological problem. And the important to recognize and to report urinary symptoms for your doctor, especially for your neurologist, is to prevent future complications like recurrent urinary tract infection, kidney stones, and chronic renal disease that is characterized by the loss of function of the renal organ. And the talk about urinary symptoms is also important to early management of other autonomic disturbance that is presented and usually concomitant to urinary symptoms like gastrointestinal symptoms like diarrhea, constipation, abdominal pain, or sexual dysfunction like impotence in male patients. Sexual dysfunction is a special autonomic symptom reported by patients with APBT and had multiple differential diagnoses. And the most clinical symptoms and complaints are ejaculatory dysfunction, erectile dysfunction, libido change, orgasmic disorders, or sexual pain. Here, I would like to present two clinical cases that typify the importance to talk about the urinary or sexual symptoms in patients with neurological disorders. The first case it's a 27-year-old Brazilian man with a 3-year history of sexual dysfunction characterized by orgasmic problem and erectile dysfunction and urinary incontinence. This patient had a family history with a father with a possible diagnosis of amyotrophic lateral sclerosis, one paternal uncle with unexplained polyneuropathy, and paternal family has a Lebanese ancestry. This patient was referred to our center to investigate hereditary amyloidosis related to transthyretin. That is a very common disease in Brazil, and that is a very mimic and chameleon for adult polyglucosan body disease because the two conditions had the same neurological problems. This patient had a negative genetic test for hereditary amyloidosis related to transthyretin, but the patient had two pathogenic variants in GB1 that confirms the diagnosis of adult polyglucosan body disease presenting with sexual dysfunction and urinary incontinence in a young man. The second case it's a 52-year-old Brazilian man with a 10-year history of gait instability with frequent falls and recurrent urinary infection and kidney stones without an etiology. This patient had a family history with a diagnosis of vascular dementia and two maternal uncles with the diagnosis of a peripheral neuropathy without an etiologic cause. This patient was treated by 5 years as a progressive multiple sclerosis because he performed a brain MRI that show lesions that are similar or compatible with inflammatory disease of the brain, like multiple sclerosis. But this patient was was treated with natalizumab and ocrelizumab, that is the best therapeutic options for progressive multiple sclerosis, and this patient had no clinical improvement and was referred to our center to investigate a clinical complaint of 1 year of neuropathic pain in the feet and the legs. This patient had a genetic test with two pathogenic variants in GB1, and the final diagnosis for this patient is adult polyglucosan body disease, manifest with gait problems and recurrent urinary infections and kidney stones. What causes neurogenic bladder dysfunction? Neu- Neurogenic bladder, commonly the first symptom of APBD. It's more common in male patients than female patients. It's commonly misdiagnosed as lower urinary tract obstructive conditions in men or overactive bladder due to gynecological causes in women. Example given menopause, pregnancy, or postoperative pelvic state. The most common associated problems or complaints reported by patients are recurrent urinary tract infections, urinary incontinence, urinary retention, recurrent kidney stones, and loss of kidney function without a clinical etiology. Other associated problems are sexual dysfunction, like ejaculatory or erectile dysfunction, and gastrointestinal problems like diarrhea, constipation, or abdominal pain. The importance of discuss about urinary symptoms with your doctor and with your neurologist. It's because the dysfunction of the bladder or urinary symptoms um, are very common in many diseases, but is a very clinical clue to a diagnosis of a neurogenic disorders like adult polyglucosan body disease. Now, my friend, dear Dr. Vladimir, he's talk about a little more about the types of bladder dysfunction and about the diagnosis and treatment uh, of bladder symptoms in patients with adult polyglucosan body disease and other neuromuscular disorders. Thank you very much.
What does urinary bladder care look like? So the management of neurogenic bladder is represented by a multimodal and multidisciplinary approach involving the need of imaging studies, monitoring renal function, urodynamic evaluation, urinalysis and urine culture, for the search of symptomatic bacteriuria or urinary tract infection, especially in the cases where recurrent urinary tract infection is present, and also uh, to provide patients the symptomatic therapy in the context of emptying or continence urinary problems. So, pharmacological therapy is patient to patient, a case by case, individual indicated. So, especially in the context of patients with multiple clinical conditions or chronic conditions such as cardiovascular disorders, the clinician may take a look at these comorbidities to indicate the best pharmacological therapy. The management of recurrent urinary tract infection is common and important due to the risk of urosepsis which such patients present, the risk of autonomic dysreflexia and systemic hypertension, and the risk of urolithiasis associated with urinary tract infection. Prophylactic antimicrobial therapy is indicated in some cases, especially to the use of antibiotics, but also antifungal agents, depending on the history of each patient. Cranberry juice is also indicated in some cases. Urinary bladder catheterization is also another possibility, and it may be done by two main routes or pathways: by clean intermittent self-catheterization or the use of indwelling Foley catheters. So it is also indicated for each case. There is not a rule which can be used, and the clinician use, for example, the routine, the personal roles, the daily activities, or other psychological or emotional and social domains which each individual has in its life, and indicates the better pathway. Surgical approaches are generally used only to refractory to conservative therapy. So patients which do not have a good control of urinary tract infection or refractory neurogenic bladder may be evaluated by the urologist to a possible surgical approach. Many different approaches are currently available. Another situation study is also sacral neuromodulation and the sacral nerve root stimulation for cases in which is present detrusor or overactivity. It is quite rare to be indicated in the main neurogenic conditions, but it needs to be more detailed, evaluated in future studies to be routinely indicated in clinical practice. So here I present the clean intermittent urinary catheter. These are the devices which are used in this situation. In these cases, the patient has the need of 3 to 4 times a day the use of the intermittent urinary catheter. There are some potential complications, for example, urinary tract infection, and some other exams which may be performed routinely. For example, each 3 to 4 months, a urine culture for a control in oligosymptomatic patients. In the case of patients in which there is difficulty or in which a continuous use of the urinary catheter is needed, the indwelling Foley urinary catheter may be used. And these are the devices, and here the representation by which the urinary catheter is displaced. Here I present also some of the several urinary bladder surgical approaches currently available. That is not the main objective of this presentation, but idea here is to show that many possibilities are also available. It depends also in the risk of a surgical approach for each patient. So discussion with the general neurologist, with the neuromuscular specialist and the urologist is quite important. Urinary tract infections in neurogenic bladder do not have only the need of care with the use of prophylaxis with antimicrobial agents, but also to take a look at some situations such as avoiding frequency, fluid intake, non-hygienic procedures, which are commonly used in daily practices, or, for example, observe patients in which there are other comorbidities such as diabetes or bowel dysfunction, and which arise the increases the risk of urinary tract infection. So the clinician take a look at these situations to better manage each case. Now I'm available to discuss the question and answer section, and I thank the APBD Research Foundation for this opportunity.